Lung cancer is, surprisingly, cancer of the lung. Patients will commonly be male smokers who present with fever, chills, night sweats, hemoptysis, and hoarseness. They may also have an exposure to radon, asbestos, or radiation, or a family history of lung cancer. Lung cancer can be split into two main categories: small and non-small cell lung cancers. The three S's of small cell are a small number of cancers, around 15% of lung cancer, smoking, and central location with an S. They are derived from neuroendocrine cells and thus may cause some paraneoplastic syndromes that you need to know. Cushing syndrome, caused by excess ACTH secretion, which I'll do a video on in the future, and SIDH, or secretion of inappropriate antidiuretic hormone, characterized by high ADH secretion despite hyponatremia. These cancers grow aggressively and as such can be more responsive to chemotherapy. They metastasize early. Common sites are hilar and mediastinal nodes, the pleura, heart, brain, liver, breast, and adrenals. Non-small cell lung cancers are adenocarcinoma, squamous cell, large cell, and carcinoid tumors. Adenocarcinoma is more common in women and is only slightly associated with smoking. Many times it is peripheral and involves the pleura, which causes it to be painful. There is some association with asbestos. It may produce mucin, and it is associated with EGFR, ALK, and KRAS mutations, which may allow for more targeted therapies. Squamous cell carcinoma shares two of the three S's, smoking and central location. It is associated with hypercalcemia secondary to production of a parathyroid hormone-related peptide. I'll be doing a hyperparathyroidism video in the future. Further, about 90% of cases of Lambert Eaton Myasthenic Syndrome are associated with squamous cell carcinoma and may actually precede detection of the cancer. Remember to screen these patients for lung cancer. Lambert Eaton is associated with autoantibodies against presynaptic calcium channels. A patient's hand grip will get better with time as calcium builds up, distinguishing it from myasthenia gravis, which is associated with thymoma. I'll link these videos here when I've made them. Finally, being of squamous origin, squamous cell cancers are generally keratin positive. Large cell carcinomas are peripherally located, associated with smoking, and are generally not responsive to chemo and have a poor prognosis. Bronchial carcinoid tumors are associated with carcinoid syndrome, which produces flushing, wheezing, and diarrhea. Liver carcinoid metastasis produce right-sided cardiac fibrosis. Lung carcinoid produces left-sided cardiac fibrosis. Both produce elevated 5-HIAA levels in the urine. To diagnose lung cancer, start with a chest x-ray in a suspicious patient. Effusions get sent for cytology, and if positive for malignant cells from a primary lung cancer, they are already stage 4. Around 10% will be alive at 5 years. If a mass shows up on chest x-ray, get a CT. If they have a paraneoplastic syndrome, get a CT to rule out underlying malignancy. Screening for lung cancer is a low-dose CT for any smoker with at least a 30-pack year history, age 55 to 80, who quit smoking within the past 15 years. To work up a suspicious lesion, suspicious meaning a spiculated lesion greater than 2 centimeters in an older, more likely male smoker, get a PET CT and biopsy any distant metastases. If no metastases, biopsy the primary lesion if suspicious. To biopsy a bronchial lesion, use bronchoscopy. A lesion just outside the bronchus, get an endobronchial ultrasound-guided biopsy. Peripheral lesions can be biopsied by a CT-guided biopsy method. Finally, excisional biopsy is possible via surgery and doesn't require using a needle, adding additional risk of pneumothorax. This method may be desirable if suspicion is high as well. Any tumor greater than 3 centimeters should be considered for lymph node dissection by mediastinoscopy or EBUS prior to any surgery, as positive mediastinal lymph nodes will affect treatment. Finally, get PFTs before any surgery to ensure the patient can afford to lose lung tissue. Treatment will usually start with smoking cessation. Treatment is complex, but the quick version is as follows. Stage 1 is basically a small tumor with no positive nodes. This gets surgery. If the patient is unable to undergo surgery, they get radiation. Stage 2 includes some large tumors and generally those with positive same-sided hilar nodes. They get surgery and adjuvant chemo. Stage 3 cancers generally have positive mediastinal nodes and get chemoradiotherapy without surgery, which is why patients with large tumors should have mediastinal lymph node dissection prior to surgery. Stage 4 is anyone with a malignant pleural effusion, cancer in both lungs, or with distant mets. They get chemotherapy only and may be candidates for certain tyrosine kinase inhibitors and other targeted therapies. Thanks for watching. Please like, comment, share, subscribe, and hit the notification bell for more great videos. Remember, if you don't want to miss it, look below and click it.